Can you listen me?
Yes, sir.
Okay, I will start now. Attendance is 51 at present. So already I have taken your 2 class on hernia, and today we'll discuss the remaining part and we'll finish the hernia chapter today. Okay.
Yes, sir.
Okay. So today we'll discuss another hernia-like conditions in the intra-abdominal walls, that is divarication of recti. So this condition means that two recti muscles separate from each other and a good gap exists between the two recti muscles. So it's also many times seen like as incisional hernia. In the midline of the abdomen, the bulging is there. So that's we will have to always differentiate it from incisional hernia or other epigastric forms of hernia. So this divarication of recti commonly found in many patients with weak musculatures in the abdominal walls. But common causes, number one is your mainly female patients, that is who is having history of multiple pregnancies, suppose multipara. So after repeated pregnancy, the abdominal musculature becomes weak and the linea alba becomes stressed. So as a result of that, the two recti muscles separates and go away from each other. And second one is repeated midline abdominal operations in which the linea alba may stretch. Because of repeated operations, the linea alba is stretched as well as weakened also. So that causes separation of these two muscles. The anatomical pathology of divarication of recti. Usually there are two recti muscles in the anterior walls, both sides of the midlines. So these two muscles are attached to the pelvis bone with a close proximity. In the lower edge, means insertion of this pelvis muscle, recti muscles in the pelvis is close, but they are quite apart in the interlateral aspects of the lower ribs, mainly in the origin side. So origin is from lower ribs, so there it is normally even away the interlateral aspects. So whenever due to stretching or due to lifting heavy weight, whatever, that these two recti muscles contract, and as a result of that, the upper portion tend to move apart from the each other, and it is also helped by the contraction of external oblique muscles as well as internal oblique muscles, which further helps in separation of the two recti muscles. Okay, next slide. So what is the clinical features of this divarication of recti? As such, usually patient is elderly multipara patients, female patients, but it may also occur old ages, weak musculatures, male patients. So during strain, whenever they do any strains, the abdominal contents bulge out through the gap between the two recti muscles, and on examinations, the gap can be detected between the two recti muscles easily. Whenever we insert the fingers, 4 fingers of the hand, the two medial edges of the two recti muscles can be felt or palpated. And similar conditions like divarication of recti also may be sometimes seen in the babies with thin bed, but that is physiological and that usually recovers when the baby grows and the good health appears. So treatment of the divarication of recti, it is usually symptomless except the bulging, and even though it is hernia-like conditions, but there is hardly any danger of obstructions or strangulations, and that's why operation is usually not necessary. But whenever it is cosmetically seems to be very bad or with huge bulging in case of female patients. Then operation may be required, and herniorrhaphy or this hernioplasty like operations can be done in that case. Otherwise, with a mild divergence of the recti, operation is not advised. Only we can advise an abdominal belt for regular uses, and thereby it prevents further progressions of the divergence of the recti. And in case of baby, whenever such type of condition is seen, it is not hernia exactly, but divergence of the recti. No such definite treatment should be advised while the baby grows. Usually, these two muscles comes towards a close proximity. Next one is your lumbar hernia. The lumbar hernia, which usually occurs in the lumbar regions, both sides, right or left sides, and usually these lumbar hernia are three types. Among these three types, the first two are called as primary lumbar hernia, which comes out through the lumbar regions, either through the superior lumbar triangles or through the inferior lumbar triangles. And the third one is acquired type of lumbar hernia, which is better called as incisional lumbar hernia. So basically, lumbar hernia is primary and acquired. The primary is either superior lumbar hernia or inferior lumbar hernia, and acquired, which is most often found as a result of incisional problem. That's why that is called incisional. So you can tell it to be two types: primary, acquired. Primary is again two types, or otherwise we can as a whole call it to be three types: superior lumbar hernia, inferior lumbar hernia, and third one is incisional lumbar hernia. So superior lumbar hernia, usually it is rare than the inferior lumbar hernia, and it is the protrusion of abdominal contents to the superior lumbar triangles. So what is superior lumbar triangles? It is a triangle bounded above by the 12 ribs above, and medially it is by the sacrospinalis muscles, and laterally by the posterior border of the internal oblique abdominis muscle. So through this triangle, the superior lumbar hernia develops as a result of primary difference. Second one is your inferior lumbar hernia. It is comparatively more common than the superior lumbar hernia, and this hernia protrudes through the inferior lumbar triangle, or that is called as also lumbar triangle of Petit. So the triangle is bounded below by the crest of ilium, medially by the anterior border of the latissimus dorsi, and laterally by the posterior border of the external oblique abdominis. So you should know the boundary of the superior lumbar triangle as well as inferior lumbar triangles. So which hernia comes out, and accordingly we have to give the name, either superior lumbar hernia or inferior lumbar hernia. Now come to the third one, incisional lumbar hernia, which may occur in the lumbar regions, either through the superior lumbar regions triangles or through the inferior lumbar triangles, but it usually follows an operation over an infected kidney or drainage of pus from a lumbar abscess in which wound gets infected postoperatively. So in the infected cases of kidney operations, or even operation may be non-infected, but later on it may be infected, the wound may be infected. As a result of that, wound gets infected and there is wound adhesions and leading to weakness through which the hernia may occur. So that is incisional lumbar hernia. And another variety in which there is that is also acquired, not exactly incisional. There are paralysis of these muscles of the lumbar regions, mainly these sacrospinalis muscles, upper part, lower part, latissimus dorsi, or your medially means laterally by the either external oblique or internal oblique muscles weakening. And that occurs as a result of injury to the nerve supply of these regions in any operations or due to poliomyelitis in the childhood. So which may cause weakening of that muscles in that parts, and that will produce this hernia. And that type of hernia is called as phantom hernia. Now, clinical features. So, clinical feature of hernia is almost same in all cases, but main thing is the site. So here, whatever swelling will be present, that will be typically in the lumbar regions, below the 12 ribs, and lateral to the sacrospinalis muscles or this latissimus dorsi. So a such type of swelling which easily fulfills all the criteria of hernia, which already I have discussed earlier in the basics of the anatomy. So on examinations, there will be soft swelling which corresponds to the superior or inferior lumbar triangles. And this hernia easily reducible. It may reduce itself, means self-spontaneously reducible, or on lying down postures it may be reduced, or sometimes manually it may require reductions. And impulsion cuff is easily present here. So the two cardinal features of hernia, reducibility as well as impulsion cuff is easily present, except strangulations or obstructions where it may be absent. So whenever there is a swelling in the lumbar regions, differential diagnosis comes as lipoma. It may be simple lipoma, but if that two symptoms, reducibility as well as cardinal features, are absent, then lipoma may be suspected. Similarly, a patient with cold abscess as a result of tuberculosis of the spines or Pott's disease. So there may be tickling of the pus to the lumbar regions, and then collection of the pus. And as it is not pyogenic, so usually it is cold and difficult to diagnose from others. Otherwise, in case of inflammatory swelling, it may be easy to differentiate. So cold abscess and lipoma are the two main differential diagnosis of lumbar hernia. And phantom hernia also comes under the headings of differential diagnosis, because as such it is not primary or it is not even incisional. So it is because of mainly injury to the nerve, not in this side, away from this side, which may cause weakening of the muscles in the lumbar regions. And this hernia should be treated mainly the primary lumbar hernia by herniotomy as well as herniorrhaphy and hernioplasty also. So after removing the shape, we can repair anatomical, do the anatomical repairs, which is herniorrhaphy, or go for hernioplasty by mainly meshplasty in between the muscle layers, or it may be only also. And if it is a case of incisional lumbar hernia or even phantom hernia, it should be treated as the case incisional hernia that we discussed in our previous classes. So basic is here also meshplasty. Another hernia which is also rare, that is obturator hernia. It is rare conditions. So it means when the hernia occurs through the obturator foramens, and normally this obturator foramen is traversed by the obturator vessels and the nerves. And this obturator hernia is 6 times more common in females than the males. So it is in short more common in female than the male, because the obturator foramen is widened in case of female patients, and in male it is narrow. So this hernia is again very difficult because the visible swelling is not so much prominent like other hernia. The clinical features, whatever you can say, usually it is old women above the 60 years of age and who have lost their considerable amount of fats. Already after the age of 60 years, easily fats are lost, skins are wrinkled. So there it is. Whenever occurs, it is prominent. The swelling can be seen in the femoral regions, medial side or inner aspect of the femoral sheath or that their femoral triangles. So it is very difficult to diagnose. Already I am telling, because in these regions femoral hernia may also occurs, or a direct inguinal hernia, or even a indirect inguinal hernia. Sometimes may get a differential diagnosis. So moreover, the swelling, which is usually the first innermost layer is peritoneum, but beyond this, the covering layer is pectineous muscles along with fibrous tissue. And that's why no such definite swelling can be seen even in this triangle, which is called as Scarpa's triangles. It is medial to the femoral vessels, not only femoral vessel, even femoral sheath through which the femoral hernia develops. Here hernia is only apparent when the limb is flexed, abducted and rotated outwards. Otherwise, in normal position, the hernia may not be prominent. So patient, whenever comes to us, they themselves will flex the limb, abducted, and they will rotate the limb in the externally. Then only they can feel or they can able to see a swelling in these regions. So for that problem, they usually comes, and usually they keeps the limb in semi-flex positions. At movement increases pain. So whenever they moves, make it stress, then it pain occurs. So hernia is very rare. Whenever presents, they also presents with pain in these femoroinguinal regions on flexion of the hip joints. As the obturator foramen is comparatively small, that's why whenever such hernia is present or can be detected clinically or by investigations like sonography or CT scan, whatever we have discussed, seen already in the basics of anatomy hernia. So there is abrasions of strangulations, and sometimes in the initial stage, whenever swelling is not visible, then if we go for parietal examinations or vaginal examinations, then lateral aspects, tender swelling can be palpated laterally, either vaginal or parietal examinations. Laterally, we can feel it. And otherwise, patient with pain or a mild swelling, not sign symptoms of abscess or other inflammatory signs, we'll have to go for investigations, mainly sonography, along with either CT or MRI, which will help us to detect such hernia. Otherwise, it is very difficult clinically to detect a obturator. So whenever such hernia is detected, either complicated or non-complicated, before strangulations or without with strangulations, it requires easily operations, and we'll have to go for operation as soon as the condition is diagnosed because of fear of the strangulations. Treatment is always here, surgicals. The surgical treatment we can go for either to the abdominal approach or to the femoral approach. The abdominal approach is comparatively better because if bowel is gangrenous, then the next step we can perform. So once abdomen is opened to a lower midlines or paramedian incisions, then it can be seen that the hernial sac entering through the obturator foramens. So without complications, it may be easily reducible, but otherwise patient with obstructive strangulations, it is difficult. So in that case, the obturator foramen will have to try to dilate so that it can come up. But there is again every chance of injury to the obturator vessels or nerves. So keeping all those things in mind, we'll have to do the approach. Now, usually a full length or a loop of bowel rarely enters through this foramens. Only a part of circumference of the hernia may enter. That is called, or we have discussed already, which is called as Rectus hernia. So obturator hernia many times comes as Rectus hernia without complete fissures of obstructions, but there may be fissures of gastroenteritis legs. So in that case, a part of wall may become gangrenous. So that will again require resection or anastomosis, along with narrowing means repair of the obturator foramens. The fibromuscular sheath is to be approximated so that obturator foramen is made narrow. Next, another approach of obturator foramen is your femoral approach. If we are sure that there is no any obstruction or strangulations, only your uncomplicated hernia is there. In that case, through femoral approach also you can go, like femoral hernia approach. Here usually whatever incision is made, that is usually started vertically. Incision is verticals below the inguinal ligaments, and it is 2 centimeters away from the femoral vessels or femoral canals towards the medial aspect. And so this way it should be open, and after opening all the layers, skin, subcutaneous tissue, fascia, it lies in between these pectineus muscles below the adductor longus. So adductor longus muscle is retracted medially, and sac is dissected out, and after that the content is reduced. Then sac is a muscle should be removed, or it can be reduced inside the peritoneal cavity, and the opening should be opening should be again repaired with non-observable social vessels, so that recurrence of the hernia doesn't occur. Now let us come to some of the rare hernia. This is the last part of the hernia. So one is your gluteal hernia. The gluteal hernia is, I am just giving the division because others are same clinical features treatment. We have to do the same procedures. So in gluteal hernia, the hernia extrudes out through the greater sciatic foramen, either above or below the piriformis muscle. So just simply remember gluteal hernia, which occurs through the greater sciatic foramen. And second one is your sciatic hernia, which occurs through the lesser sciatic foramen. And in the differential diagnosis of gluteal and sciatic hernia, in both these two, because it may be gluteal hernia is only whenever it comes to the greater foramens. Sciatic hernia whenever it comes to the lesser sciatic foramens. So here also differential diagnosis come as a collapses, lipoma, or a gluteal aneurysms of the artery, and last one is fibrosarcoma beneath the gluteus maximus muscles arising from the pelvis. So all these things should be also kept in mind before diagnosing a sciatic hernia or a gluteal hernia. Then another hernia is Spigelian hernia or Spigelian hernia. So it is a type of interparietal hernia, occurs at the level of the arcuate line just lateral to the rectus muscle. So These hernia also very difficult to diagnose. Here is just to give importance on the arcuate line. What is the arcuate lines? And which one is the lateral body of the rectus muscle? So, in the lower abdomen, the posterior rectus is deficient from a point towards the distal sides. Just below the umbilicus, about 1 inch or 1.5 inch away, the posterior rectus is absent, and the lower margins of the posterior rectus that line corresponds to the arcuate. So, in this line, just lateral to the rectus muscles, it is almost Meiboni's points or ME points in the right or left sides. So, in this case, a type of hernia arises, which is described as interparietal hernia, mainly inside the abdominal. Because here, whatever hernia occurs, that is mainly this preperitoneal fats along with the peritoneums enters to the fossa places, and it is remained below the internal oblique muscles, or sometimes it may again penetrate the internal oblique muscles and it may remains just below the external. And that's why here external oblique muscles or epinosis is almost intact, and that's why the swelling is not so prominent, except a fake type of swelling is there. So only sonography or even MRI may give this type of diagnosis properly. So once if such type of hernia is diagnosed, then again operation is same. Here we'll have to go for herniatomy as well as repairs. Or nowadays, if there is big gap, we can put a mesos. Next, another rare hernia is perineal hernia, where hernia occurs through the pelvic floors in the perineal regions. So it is also rare. Mainly it occurs in a case in the perineal scars after excision of the rectus, mainly case of APR, abdominoperineal resections. And if a rectum is completely excised from the perineum along with the anal canals, and there the wound or the defect in the anal regions is closed. But later on, through this way, if the pelvic floor is weak, if not repaired properly, then herniation may occur. That is called as postoperative perineal hernia. Second one is pudendal hernia that occurs mainly in female to the labia major or labia majora. And third one is iceraphthal hernia, where the hernia passes through the levator ani or through the hiatus valvi into the iceraphthal. Mainly through the levator ani muscles, which is forming the pelvic floor, through which herniation occurs and it enters the iceraphthal. It is lateral to the your anal canals regions. Iceraphthal hernia. Okay, so these are rare hernia. So we have discussed the basics of the hernia in the very beginning process. Following that, you'll have to know the inguinal hernia, this femoral hernia, epigastric hernia, umbilical hernia, incisional hernia, and today we have discussed all these bifurcation of the recti, lumbar hernia, obturator hernia, as well as the rare hernia, gluteal hernia, sciatic hernia, disphysial hernia. And those other rare hernia, those are clinical entity like those Rectus hernia, Litus hernia. Okay, our time will be over the past 40 minutes. Once the screen is off, you just wait to resume the next part. So with this shortly, in my 3 class, I have finished your hernia subclass theoretically. And next, I'll start the topics mainly scrotum and the testes. So today we'll discuss not the disease proper, but something about the testes as well as the scrotums. Okay, so before going to the different pathology in the scrotum, like undescended testis, ectopic testis, then your testicular torsions or hydrocele along with testicular tumors or even testicular trauma, whatever. So those things we'll discuss on one or before that. We should know something about the embryology of the development of the testis. To understand mainly undescended testis as well as ectopic testis. So testis usually development start at the 5 weeks of intrauterine lives, mainly from a thickened epitheliums on the medial side of your mesonephric ridge, both sides. And from these thickened epitheliums, the gonadal ridge appears by the 7th week of intrauterine lives, and it projects towards the coelomic cavity. And this thickened epitheliums, which mainly helps in formation of the testicular tissue along with its covering, the mainly the tunica albuginea. And from this epithelium, from the surrounding tissue, that is mesenchymal tissue, the testicular cords appears, and which helps in formation of the testis. And surrounding mesenchymal tissue, that helps in formation of your some fibrous cord, that is your gubernaculum testis. And whenever the testis descend down, this gubernaculums, along with this, a fold of peritoneum also descends, that forms the processus presens. And this processus presens usually gets obliterated at the level of epiminal lens. Along with the whole Ethanolase process or canalization that is stops in a normal conditions. Now, what is the exact your time of testicular descent? Usually, testicular development, already I have told that this testis developed from thickened epithelium, and development starts from the 5th week of intrauterine lives, from a thickened epitheliums, and from the surrounding mesenchymal tissue, which also helps in further descent. Along with time to times, the testis develops and it descends down. And the period of the descent, usually in the 2nd month of lives, means that is by 8 weeks, up to 2nd month, 8 weeks, the testis remains in the lumbar regions of the fetus. And in the 3 months, 3rd month, it comes to the right iliac fossa. And up to the end of 6 months or to the beginning of the 6 months, the testis remains at the level of the deep inguinal ridge. And during the 7th month, the testis descends or it enters into the inguinal canals. And at the end of 7 months, the testis reaches the superficial inguinal ridge. And at the time of delivery, by 9 months complete, the testis remains in the scrotum. So that's why many times in the premature baby, the testis, if the baby is born at the 7 months, testis are not found properly in the scrotums. It may be in the superficial inguinal levels. So in this baby, if you wait 1 or 2 months up to 1 year, the testis may descend even later period. Now, what are the factors which causes descent of this testis? Among that, number 1 is your shortening and active contraction of the gubernaculum, which develops from the surrounding mesenchymal tissue of the gonadal ridge, which develops from the epithelium. So that forms a fibrous band attached to the testis, comes along the testis towards the scrotums. And second, so main is the softening and active contraction of the given. And second one is increase intra-abdominal pressures. So mainly due to abdominal pressure also it comes down. Third one is active contraction of the lower fibers of the internal oblique muscles. Mainly from the deep inguinal vein levels it comes down. Then another is high temperatures in the abdominal cavity comparison to the external environment. And this test is whatever spermatogenesis process that occurs properly in a comparatively less temperature than our body temperature. That's why by naturally also according to temperature it comes down. And another is hormone, that is human chorionic gonadotrophic hormones, mainly maternal hormones. Nasal person that also helps in descent of the testes. Probably it stimulates the testes to descend the normal directions. So all these factors, gubernaculums and contraction of the internal muscles, abdominal pressures, along with maternal chorionic gonadotrophic hormones, which stimulates in that tissue. So any abnormality in this leads to undescent or non-descent of the testes, in which case testes will be absent in the scrotums. So causes of undescent testes are abnormality of the gubernaculum testis. Second is intrinsic testicular defect, where the testicular tissue may be insensitive to the chorionic gonadotrophic hormones, normally which is sensitive and it comes down. Then this maternal chorionic gonadotrophic hormones may be deficient or lack. As a result of lack of stimulation, it may not come down. Then in some cases, the first difference, which is developed from the mesotrophic duct, that may be shortened testicular vessels. So shortened testicular vessels, tympaniform plexus of veins, along with shortened ductus difference. And if this testicular development, whatever normal testis development occurs, if that is abnormal in the development of the reti testis, then interstitial tissue along with seminiferous tubules, all those things is abnormal. Means otherwise, in a word, abnormal testis also occurs as a non-descent of the testis to the scrotums. So today we will stop here by giving these introductions. Mainly the development of the testis. Embryology you should know something. Then causes of descent as well as causes of undescended testis. Then anatomy, you should know what is the layers of the testis, what are the layers of scrotums. All those things you should read from your books. And next class I'll discuss the disease or topics proper regarding testis as well as scrotum. So today we'll stop here. Thank you.